Welcome to our NHSN AUR work group for the Chicago acute care facilities. I just want to remind you guys that we are recording this presentation, so it is publicly available on our Chicago Han website for anybody to reference after our meeting. I do want to make some quick reminders. Please introduce yourself in the chat so that we can all get to know each other. Your name and what facility you're from would be helpful. And if you do not see the slides advancing, our CDPH slides automatically, please select the link to presenter under the slide deck if it prompts you to. So we'll go ahead and get started. Our quick agenda for today, we're going to do some welcome and introductions, and then we have our guest speaker presenting on how to leverage NHSN AUR data. We're going to be talking about data sharing for our antibiotic use and antibiotic resistance, and we'll be going over our ICAR, which is an infection control assessment and response tool produced by the CDC, and then we'll leave it for question and answers and open discussion and some other announcements that we're going to talk about. So to get started, we are honored and thankful to have Dr. Libby Dodds-Ashley. Dr. Dodds is a professor in medicine and director of operations for the Duke Antimicrobial Stewardship Outreach Network, also known as DASON or DASON, based at Duke University. She has been an active role in antimicrobial stewardship pharmacist for more than 15 years. Her work and her research and stewardship span in a variety of patient care settings, including large academic medical centers, community hospitals, long-term care facilities. She serves as a member of our antimicrobial resistance work group at the CDC and an expert panel member of the Transatlantic Task Force for Antimicrobial Resistance, among other appointments. She also serves as the Society of Infectious Disease Pharmacists representative on the Presidential Advisory Council on Antimicrobial Resistance Bacteria, also known as PACCARB, and she's actively involved in several professional societies engaged in stewardship, including SHEA, SADP, for which she recently served as president. So please welcome Libby. I will unshare so you can go ahead and share.
Thank you, Star. And hello, everyone. It's nice to see some familiar faces. Hi, Larry. On the call, let's see if I can share this. Let's see. All right. So I am here to talk a little bit today about a project that actually has recently completed with the CDC. And hopefully, as you're all going down this journey of reporting your AUR data, it will be helpful to you. I think one thing that a lot of us know that DASON, or what we're known for in DASON, is how we like to spend a lot of time looking at our data and visualizing our data. And that's what we've tried to bring forward to the CDC, is how we take the data such as that you use in NHSN and use it to guide our stewardship work at the local level. And so go ahead. Let's see. Just, I know this isn't CE, but I always disclose that I have one consulting relationship with a diagnostic company. When the CDC heard I was giving these talks, they did ask me, I know this is something you all have covered here a lot, but they were like, please always just start with this. So I will. We're now in calendar year 2024, so it is now a requirement to in some way be engaging with the AUR reporting module within NHSN. The good news, and I think so a lot of my sites that we work at in DASON got really nervous about this, but you have some time. This will actually be measured on January 31st of 2025, but you need to have your submissions in for both AU and AR at that time, or be actively engaged in the process. And we've learned a lot. So we have actually gone through this, and we are now an accredited vendor for reporting AUR data. We have successfully gone through getting the credit for it for 3 of our hospitals for calendar year 2023. There were bonus points that were eligible. The end of time to report that was yesterday. So that's all said and done if you haven't already done that. But we've learned a lot along the way. And I think instead of just going over the requirements and the rules, and I just want to remind everybody that this metric is part of the promoting interoperability. And here on this slide, you can see all the things you have to do to get points. There are lots of things required on that list. And so this is not standalone to stewardship, and it's actually working in a world that was different for us in all of our hospitals. In all the hospitals and health systems where DASON works, I have had to meet a new person who is responsible for this. And so that is first and foremost, is if you are hard at work at this at your hospital and you have not gotten in touch with the person who is responsible for the PIP, the Promoting Interoperability Program, at your hospital, you need to. We stumbled across in 3 of our hospitals That group was actually doing their own work to hire a vendor for something we had already been doing for them for the past years. So be sure you reach out and meet that person. There's a lot that has to be done. Know what you need to do, but most importantly, don't panic. Because what I'm going to show you is on the back side, we're going to get lots of valuable data from this that we can use going forward. I also like to remind everybody, I think there are some expectations of the SAR data when we start telling people that you're going to have antibiotic data that's risk adjusted. People get excited and think about lots of things that are and maybe aren't provided by the data. So just as a reminder, the SAR models are currently based on antibiotic use data from calendar year 2017. Adults and pediatrics are modeled separately in all the models, but we had a much more robust data set to inform this model than we did for the initial 2014 models. So there were over 2,000 adult units included and hospitals from all 49 states, whereas in the initial models, it was heavily driven by data from the VA health system. We now have lots of different unit types included, and very exciting is that work has already been started at the CDC to do a rebaseline. So there will be a calendar year 2023 baseline based on all the data we've all been busy submitting. So if you are a hospital that does submit your AU data, stay tuned for questions from the CDC about validation of certain aspects, and be sure you reply, because we want to get up to as many units informing the new models as we possibly can. And I suspect that we'll also get more location types included in these new 2023 models, because lots of additional unit types are now being reported, which is exciting. The risk adjustment has, and for these new models, will remain at the facility level. And so these are data elements that come off of the NHSN annual survey. And I still have hospitals where stewards are not participating in completion of that survey. And I can't encourage you more than going in and getting involved with that, because this is how your data will be adjusted. We find things all the time that need to be corrected and really do swing the results we see for our SAR estimates for our hospitals. So once you get to the point where you're actually submitting your data and you want to have more output that you can use, this is kind of the fun part of the talk. So we have to go in and get our data. If you haven't been in to NHSN lately, this used to be a very small list, but now the antimicrobial use data folder in the analysis tab is very robust in terms of all the things you can get, which include all the antimicrobial use data reports, as well as this semi-new category, the TAS, the Targeted Assessment for Stewardship Reports. Super exciting. I think what most people do when they first get their AU data into NHSN is they go and they click this initial SAR report up here and try to look at the output. And you get something like this, and I think people are often a little bit stymied. So where do I go from here? I have this data output, has some things in yellow. And if you're not that familiar with the NHSN output, everything in yellow is actually calculated through NHSN. So the big category is that first wide one is the number of AU days predicted. That's how when they apply the model to your facility and location type, that's how many antimicrobial days they would predict that you have. That gets compared with the days you import, the column to the left in white. And that ratio is quite simply your SAR. And then you can also see there the p-value for your SAR and your 95% confidence interval. But then what do you do with this? You know, I often get the question, and everybody can sort of chuckle at it, but I think it's a valid question. People will say, you know, I've been submitting data into NHSN for 3 years now, and nothing has changed. Well, the good news for stewards out there is we have a lot of job security, because just reporting the data is not going to do anything about how we use antibiotics. These data are hopefully the tool we need to convince prescribers how to do things differently. And so that's where our team at DASON has been working over the past year on the CDC-funded project. It was a huge team. We had all the DASON pharmacists and physicians. We had the CAUSE team, which is the Carolina Antimicrobial Use Stewardship Committee over at UNC. So we had both shades of blue from North Carolina adequately represented. We also had external consultants from our IT group and the CDC. We actually also worked with a medical librarian who specializes in data visualization to give us some tips and tricks on how to improve what we were showing you. So we worked together to come up with use cases, and that's what I'm just going to quickly give you a sample of today. I will jump ahead and tell you that on the very last slide, there's going to be a QR code that links to the website we developed for this project. There's new content. We had to do some slight graphic changes to meet some website reporting. So there's a few things not there yet, but they will be very soon. But most of this content's available for you, as well as additional case examples. So the first question I feel like I've always been asked as a steward is, do we really use more? And this is a way, and I think it's something you're going to discuss a little bit later on in the call after my presentation's done, is how can we look at that? And using the tools in the NHSN group function. So if you all join a group, there's a few additional reports that weren't on the screenshot I just showed you, that you can look at all the facilities. You can see here, we have our own fictitious hospital at NHSN that has simulated semi-real antibiotic use data. But you can see here, you're able to very quickly go in and pull down the SAR data. This was annualized SAR data for a whole cohort of hospitals. And within Excel, very quickly, we were able to take a look and see where you are. So you can actually say, gosh, we are among the higher here in our test facility. So we might use more antibiotics than some of our counterparts. That is great to getting past that initial obstacle in the conversation. It alone doesn't change antibiotic use, but it certainly opens more doors for me. Now, because we have data, there's actually ability to also benchmark. So, it used to be we were all targeting the SAR of 1, where our observed and predicted were about the same. But the reality is, since that initial baselining in 2017, we've all been doing antimicrobial stewardship work. And so lots of places might be going down. And in fact, now we have these data. So if you look at the 50th percentile for all antibacterial agents in adult locations, SARS, you can get that now from the CDC. I'll show you how in a second. We can now compare to that. It's actually slightly below 0.9 at this time. So really shows, hopefully now, if you're at one of those hospitals where you keep saying, I think we use more, I think we use more, now we have the tools to answer that question, and it's risk adjusted. Again, at the facility level, not the patient level, but really this does help say these hospitals are more similar to us, and it's available to very granular unit type comparisons. So where that benchmark came from, it's actually from the CDC. They have the annual antibiotic use report that comes out. That is easy to link to from the CDC website. So the data comes out for a full year, about a year after the end of a calendar year. We typically get it as our stewardship gift during annual antibiotic awareness week. And so it comes out in mid to late November. So we just got the 2022 data, which is exciting. And then all of this data are actually uploaded into this patient safety portal. So you can get the data for different SAR categories right down to your state level, right out of that portal. So you can go in here, you can see here, maybe I should have done Illinois, but here's North Carolina, and the SAR category was for all agents, all antibacterial agents in adults. And you can see the 50th percentile here is slightly above the national percentile. Here in North Carolina, we're at about 0.915, which really helps you make a comparison to other hospitals in your geographic region, which I think is nice. Now, I do get asked a lot, and so I'm going to go slightly off topic here and talk about the value of having a static model for risk adjustment versus these continually updating data. And what I'd like to say is I often get asked, and I know Arjun and Melinda at the CDC get asked a lot, calendar year 2017, that's fine. Now we're going to have updated models for 2023. But wouldn't it be better if we had updated models every year? My argument is no. If we updated our models every single year, how would you show your own progress if you're comparing constantly apples to oranges? So by having a fixed model that we update routinely, but not annually, you can see how you progress year on year compared to your own goals. But now that we also have the data on annual trends, we can also see the progress that everyone else is making on these goals and seeing if we're falling behind in terms of our progress. So with these reports that come out annually from the CDC, the antibiotic use report, and all the data that's uploaded into the patient safety portal, we can easily see our progress, but also use those fixed models to be able to compare our work over time, which I think is really ideal. Now, some other things from that annual report, because I know there's a lot of pharmacists on the call, there are so many tools there. Here you can see the time trends for the various pooled mean SAR categories. You can drill down by different unit types. And then there's this fantastic Excel spreadsheet you can download. What pharmacist doesn't love a great Excel spreadsheet full of data? And you can get all of these things. These are updated from the 2022, but if you have your list of top 10 agents you use in your medical ICU, you compare it to the country. I pulled that right out of one of the tabs. I haven't even counted all the worksheets in this Excel file, but I highly encourage you to go there if you're looking for ways to compare and contrast your data. One of the nice things that they give here is they give the percentiles, and that's on the table kind of on the left-hand side of the slide, is it shows you what the 5th, 10th, 15th percentiles are for SARs for these different unit types for whatever SAR category you're interested in. We have found that this really helps speak about the SAR in our facilities when we say you are in the 95th percentile and not in a great way for how you're using antibiotics. Now you might say, oh, Libby, that's a little cumbersome. Do I have to go out and pull down this data every time I'm interested in sharing it with prescribers or leadership or talking about my stewardship data? And the great news is that those initial outputs always now have your SAR percentile for the category as the last column. So your data gets right into your reports now. And then just to orient you a bit for the talk, every time I show an extract that's directly out of NHSN on these slides, the exact report that I pulled off the NHSN list by its name is included on the slide, and then any modifications I made. So in this case, I went and I pulled down the SAR report, all adults and peds SARs by location, modified to present data by quarter instead of monthly. And that will persist throughout this presentation. So really exciting. So I've shown you how you can compare your SAR data to others in your network, which I think is incredibly valuable. It's what we do in DASON all day long, and it really has helped us bend the curve at a lot of facilities that always thought their use wasn't really that high compared to their peers. But time trends are something else that's so important in our stewardship work. And the SAR outputs really give you help in doing that. So you can do time trends. There's actually a SAR plot. This was through work actually from a dear infectious diseases pharmacist colleague, Amy Packus. She worked hard to help develop these best outputs. And what you see on the left-hand side is how you can directly output this. It is a SAR plot that includes your SAR as well as the 95% confidence interval, shows it to the comparison of one. Easily you can export these and put these right into slides if you like. So it makes it easy for you to share these data, but also using the raw tables that I showed you previously, you can export the data right into Excel and manipulate them as you like. And that's the same data over on the right, just prepared in Excel. So easy for us to do as students. So we've shown it, we're the problem. Where do we start with our stewardship work? So sometimes just identifying that it's a problem is a huge step forward to take. But then how do we drill down and make the smartest decisions about our antibiotic stewardship interventions? I'm old enough to have sat in a lot of rooms with stewards where intervention planning would go something like, oh, hey, we're spending a lot of money on Pip-Tazo. We have to get that under control. How should we do it? And the ID experts would sit in the room and scratch our heads and go, oh, I think we must be using the Pip-Tazo for treatment of nosocomial pneumonia. So let's come up with new guidelines about where we want to use it and implement those guidelines and measure the use, and nothing about Pip-Tazo would change. So we go out and do a point prevalence survey and find that actually we were totally wrong about where we thought we saw Pip-Tazo being used. And it was actually being used in a totally different area of the hospital or for UTIs and not nosocomial pneumonia. We have to start over again. We waste 18 months in the process. What I'd like to show you is that using the NHSN data, we can be smarter and drill down in how we use these data today to help guide our stewardship interventions going forward. So lots of ways to do this. We can drill down now to specific agents that are contributing to the SAR. I find this absolutely fascinating. So our SAR is high, but why? And this is the work that you find primarily in those targeted assessments for stewardship, the TAS sections of NHSN. These are from the reports. It's its own folder in that reporting analysis tab. And so this particular one is the TAS report for adult SAR types. And what you see here, these are data from my test facility. You get each SAR category. You get where it is in its rank. And what do I mean by its rank? And what is an AUCAD? AUCAD stands for antimicrobial use, cumulative attributable difference. I know that doesn't always seem very intuitive, but it's basically the difference between your observed and expected. It's somewhat simple subtraction, but it's nice to see that here and ranked. I like to think of this in my head. I know that's not the official meaning of the term, but I like to think of it as conservable antibiotic days. So this is where you may have opportunities if you believe that risk adjustment. And so area you look here, my overall for all antibacterial SAR is my highest area of opportunity. where I have almost 2,000 conservable days potentially. You can see from my second category, that's the broad spectrum for community-acquired infections. But in both of those categories, the single largest drug driving that SAR is ceftriaxone. And so that gives us a really great place to start and think about. Now, sometimes this might actually seem just a little too overwhelming to start there. So you also can see other places where there might be opportunities. Important to note that whenever you see a negative SAR or negative, sorry, AUCAD, that means that you've already met the goal. So that's how much you would have to increase your antibiotic use to get to your goal. And you might say, so what is the goal? In these examples, I've set all the goals to 1, but in the front page of your NHSN, if you go to the task dashboard, you can actually set what your SAR goal is. We have some health systems where DASON consults where we have very specific SAR goals already in place. And so we can put those SAR goals in and calculate with a click of a button what it is going to take to get there. Here's a little bit more of the drill down. You can also pull those AUCAD data down by location groups. And so you see here, we have wards, oncology, step down. These are all the places where we have looked and seen where we have the most opportunities. And so you see our ICUs are actually doing okay, whereas we have a lot of work to do in our wards, and oncology came in second. But maybe 127 DOT changes is a little bit more reasonable in terms of the workload we can do, so it might be worth putting that effort in. Now, you can also use these data to help prioritize where you're going to go. And so there's additional reports in the task reporting group that gives you location groups. And so it says if you have a really engaged steward in your ICUs and you want to know what they should work on, maybe it's different than what you're going to do in your step down. So in the ICUs here, in my example, it really focuses in on those broad spectrum agents for community acquired infections. Again, ceftriaxone being the highest, but in step downs, it's the drugs associated with C. difficile. So you can see we really have differences in our locations, and it allows you to sort of divvy up the work. And maybe it isn't that all of my clinical pharmacists are working on ceftriaxone. Maybe you'd find a trend for antifungals somewhere and you have a targeted pharmacist in that location doing that. And then overall, everyone's working at their own priority area in a smart way to really change the overall picture of use towards more optimized. Because I think something that always deserves saying when you talk about SAR data is these data are based on predicting your antibiotic use amount on risk adjustment criteria from 2017, when we know from other data from the CDC, half of all inpatient antibiotic use was inappropriate. So even getting to your SAR goal of 1 means you're getting to that baseline rate of inappropriate use. There's always opportunities to improve. Now, you also can pull just overall, what are the top unit and SAR type that needs my attention? And here are these ranks. So the 1, 2, 3, and 4 are on my wards. I know in my hospital wards are where it's at. But when we look at this in other hospitals, it's mixed. Location group for the top one might be wards and the broad spectrum community associated. Rank 2 sometimes is the ICUs and the antifungals for candidemia. So you can take a look and very nicely start to prioritize your overall use of drugs and use of stewardship resources. Another really important way that I think we can use these data is make sure we're setting possible goals. When we first started showing our hospitals our SAR data, we saw a very interesting response, and that immediately leadership was lashing out at these and saying, okay, if our SAR is 1.2, my new SAR goal is 0.8. And we're like, oh, well, we need to think about that. Is that even possible? And this is another way that the task can help. This is that task dashboard that I mentioned, and this is where you go in and set your SAR goals. Again, for this presentation, I've set them all to 1, but you can set them wherever you like. And then you immediately get a graphical representation of those AUCADs, and then what that CAD is so you can look at it, which is helpful. But how do I use this to decide if I'm being smart about resources? Well, if you're going to go in and if you have an overall goal of taking your SAR down quite significantly, and I tell you just to get to 1, that means for some quarters, if you look right here, we had to decrease our antibiotic use by 892 days of therapy. What does that look like in a year? Have you put the resource in that can really review or change that many days of therapy every single day in your hospital? Usually the answer is no. And so we've been able to leverage this data to show the resources we might need to be able to really affect the change that's desired. And that's a very helpful tool for our stewardship programs. Now I'm going to quickly go through some ways that we can use these data to really target specific interventions. And this is the sort of thing you're going to see on the website I'm going to share with you at the end of the presentation. The first is IV to PO. I think a lot of people are surprised and forget that you can actually do IV to PO tracking using the NHSN data. These are data we exported, we put into Excel into quick pivot charts. We are able to very quickly compare digestive tract administrations and intravenous tract administrations right in the Excel spreadsheet that way, and you can see that here for doxycycline. Over on the right of this, with a very simple calculation in that same Excel spreadsheet, we can instead track the percent of doxycycline administered orally, which is a useful metric as well. Now, I'm not going to be able to go through all the material we have, so let me show you the framework of this project. You can see our fancy logo there. That's how you know it's a real project. But what we did is we have developed 15 clinical scenarios. They are grouped into 3 different categories. And you can see they're sort of approached by the type of problem you might be trying to solve. And then there are different examples that fold out under each of these. And then we realized that sometimes it might take some minor manipulation of the SAR data. In a few cases, some additional augmented data you want to add in. So we came up with metric guides that show exactly how we do this. And I'll be entirely honest, when we started doing this ourselves and we wanted to figure out how to merge files together appropriately, the DASON team, quite frankly, spent a lot of time on YouTube where you can find these great videos of how to do a similar function of people doing something in Excel or another platform. So we created these metric guides, and with that in mind, we thought we'd save you having to search YouTube yourself. And we also, for these metric guides, have what we call affectionately StewTube. And these are little video snippets where you can see us, different members of the DASON team, going through with screen capture exactly how we exported the data from NHSN and then how we manipulated it in Excel, what additional data we added, etc. Sometimes we also include data that we get locally at the site. And whenever that is the case, there is a blank Excel spreadsheet also linked there so that you can download it and take that to your meeting with your local IT department for what data you would like filled out. Sometimes having that as a start is a great way. And if you get it back in that format, it matches what we use in our StewTube videos. So you'll be able to also assimilate the data quite nicely. Now, my next example scenario is surgical prophylaxis. This happens so commonly. Maybe you had a prophylaxis guideline update in the past year and you were hoping to eliminate postoperative antibiotics. If you've had success, congratulations. We want to learn more about that. But you can actually use the NHSN modules to assess this. So here you can see here some data out of my test facility. And when we look at different locations, we're actually using a fair bit of cefazolin in our surgery unit. And so we're interested in finding out, can we drive that down by decreasing this postoperative antibiotic use? Well, it isn't actually that hard to get average durations out of NHSN if you have a little bit of local data. In order to do that, you already have your days of therapy. All you need is the IT group to be able to give you a count of medical record numbers that got cefazolin. Because if you can just, it's a simple division, you can easily get your average length of therapy, which is helpful. So you can tell, yep, I'm decreasing my average durations. And so maybe that's the impact of my no postoperative antibiotics because they're shorter, although arguably you'd hope they'd be non-existent. You can also do this specifically in patients who had procedures. Now, NHSN has data for targeted procedures, and I'm sorry, there's a typo on this slide. It's not cyst, it's colo. So your prosthetic knees, your prosthetic hips, your hysterectomies, and your colon procedures, those all get uploaded into NHSN. And so you have that data and can bring it down. And actually, you can look at the individual cases if you can link the data. And we show you how to do that in several cases. But there's also somebody at your facility who likely has counts for lots of other procedures at your site. So there's lots of ways that being just a little bit creative, you can take the data you're putting into NHSN, pull it down and use it to greatly inform your stewardship work locally. Now, we only had a brief 30 minutes today, and I hope I've sponsored some thoughts, and I'm interested to hear your questions. But before I turn it over, I just want to, talk about how I would start thinking about using the NHSN data in your stewardship work. One, if you are involved in stewardship and don't already have local access to NHSN, get it. There's so many tools in there, and they're putting more in all the time. They have user feedback calls, and they really take that feedback and build new reports. I'll be honest, those AU CADs came out of conversations the CDC had with the DASON team and others that were like, yeah, we're doing this simple subtraction to see how many days different we are. And they built this fairly robust analytic tool off of it, which is fantastic. So it's really easy to get your data out and to be able to manipulate it in a very simple fashion. Now, you also need to be realistic. You need to not expect it, like I told you at the beginning, to have the just reporting process change the antibiotic use. It's how you use these tools, but don't underestimate the power of comparison. People are naturally competitive, and that really can help you. And then collaborate. Like all of you here on this call already collaborate a lot in stewardship work. So the more you can share and compare with each other, great things come out of it. And again, it's how the CDC informs our future work. So I hope this quick review has been helpful. Um, I love to hear from all of you. So there's my email address. There's the QR code, or if you forget, there's a public link to our website with all those tools on it at the DASON website. If you just Google DASON, don't Google Dyson, that's the vacuum cleaner, and the great hair dryers, DASON, DASON. You'll be able to find all the links. And with that, I'll turn it back to you, Star, and I'm going to stop sharing so I can see all of you.
Sure. Thank you so much, Libby. We have time for questions, so if anybody has any questions, wants to come off of mute or wants to drop them in the chat, we're more than happy to answer those. But I have a quick question. So a lot of our facilities right now are in the process of getting started with NHSN. So but obtaining C-suite buy-in is like a big thing with getting these applications to be added into their electronic medical records. So what advice or any tips and tricks that you may have for those facilities that are having those types of issues or barriers?
Yeah, so that's a great question, and we struggled with that for a long time. I think CMS has made it much easier for us because now there's hard money on the line. It's hard to get a true quantification of what the penalties look like. And again, AUR reporting is just one of the required elements for that PIP money. It's kind of all or none. You either meet the score or you don't. But what we're told is that for hospitals, it's always in the millions, and it can go up to above, anywhere from like 3, 4 million to over 30 million, depending on your hospital and your reimbursement. So I think now it's actually interesting is that there's very little resistance to getting it. It's just that often the people who are responsible for it don't even often know that your stewardship program exists. So I think the bigger thing now is go find those promoting interoperability people and make sure it's getting built in a way that's most useful to you.
That's super helpful. Anybody has any questions for Libby before she jumps off? Because I know you're probably super busy. Or if not, you guys have her email available. We will have these slides again available for public facing on our Han website, so that way you guys can see them. But yeah, thank you so much, Libby. I really appreciate it.
Yeah, thanks for having me. Good to see everybody. Have a great weekend.
Thanks.
Thanks, Libby. That was terrific. I love the stew tubes.
Yeah, that was super cool. And it's really helpful that it's on there for everybody to see.
Well, I'm glad you like it because I think the Dason team was mortified I made them make videos. So please compliment them all on their fantastic work.
Yeah, that's super helpful.
All right. Bye-bye, everyone. Thank you.
Bye, thank you. Okay, so we have NHSN data sharing, just a quick intro to that. So a lot of facilities have questions about data sharing and our data use agreement. So I just wanted to make this educational slides for you. So the CDC and our either local and territorial health departments, that includes state, have a data use agreement. So a DUA is what we call it, where the health department will gain access to data reported to the CDC's NHSN from healthcare facilities in whatever jurisdiction your facility is at. There are designed to allow access specifically and only for the use of surveillance and prevention. So the overarching goal of the new access provisions is to enhance the value of data reported into NHSN for public health purposes. So a lot of questions with that. Please check to see if your facility is data sharing is the main point, especially given the NHSN mandate that we are able to see your data. I know a lot of facilities are currently reporting and we're able to see that data, but just to make sure that you are opted in into sharing data, because automatically in Chicago, and I think in Illinois as well, you are automatically opted out. So you have to opt in on your DUA agreement in order for us to be able to share or for you to share your information with us. Some common questions that people may have is how is this data going to be used by the health department? So again, it's used for healthcare associated infection surveillance and prevention purposes, not legal or regulatory. The city of Chicago, we are not a regulatory enforcing. So there will not be any like regulatory action taken upon your data that's submitted. Who in CDPH has access to this data. So this data is intended for the city of HAI or the city of Chicago, our HAI program and prevention activities. If you guys have any questions, you can contact me or our HAI Hira Adil, who is our program manager for the city of Chicago with any questions or concerns. Again, people have questions on what will be included in the data use agreement. So each data use agreement is modeled using a template developed by the CDC. It's customized by CDC and CDPH and will reflect local data needs, protections, and policies. If your state or your city has a data use agreement, the CDC will make an agreement publicly available on the CDC's website. And it's important to note that past data, so any data that was entered previously, will not be shared, only the future data once the DUA is shared with the health department. Will facility identifiable data be publicly made available? That is a common question as well, and we want to just enforce that no, any facility identifiable data publicly available would be a violation of the data use agreement, and the CDC will terminate that data use agreement immediately with us. So we are not allowed to share any of your information. Anything that we do have will be de-identified information if it's publicly made available. Does CDPH entering into a data use agreement benefit my hospital? So many state and local health departments have effective and collaborative relationships with facilities in their state, including prioritization of prevention programs and opportunities for undertaking complementary HI prevention projects. So the DUA may foster additional collaborations between facilities and CDPH in this manner. So just some things to note. And then I want to talk about our monthly planning or your monthly planning reporting plan that you can set up on your NHSN as well, which will allow us to share that data. So for your monthly reporting plan, you have your module that you will enter data into each month, and you guys might be familiar with it. Some of the IPs that are currently reporting for CAUTIs and CLABSIs. You can also include data for the antibiotic use and resistance module, which you can see in the bottom section. Please make sure that you're including CDPH reporting requirements plans is included, and you may add on plans ahead of time for each month or for the entire year as well. So what this looks like, or how you can set it up, you need to add the AU option to your monthly reporting plan for every month that you plan to submit AU data. You cannot enter AU data off plan. So from the NHSN homepage, you will select the reporting plan in the left-hand menu, which is the picture that we showed previously. Click Add to add a new monthly reporting plan, or Edit to edit an existing plan. You will select the month and year for the AU data submission. And if you're editing a previous plan, you just scroll down to the bottom of the page and click Edit, and then you will select the antimicrobial use and resistance module section of the plan. You will enter the locations for which you are submitting the AU data for that month, and you will check the box, AU box. So you'll see the screenshot that I have in the next slide. And you will include facility-wide inpatient in the monthly reporting plan for the AU option, and you must have at least one individual non-facility-wide location. So for example, like a medical ward and an emergency department added to the plan, and then you will hit save. So what that looks like is on the next slide. So as you can see, you select the box for AU and AR, your facility-wide location, and as well as the other locations that you want to be included as well. So you can select also antimicrobial use or antimicrobial resistance for either of them, and then save. More information on this, there is a lot of CDC and NHSN AUR training videos available on the CDC website and on their YouTube channel. So more information about how to look at the AU data that Libby was talking about. So, and analyzing that data for beginners and advanced AR option data, so again, looking at reporting and analysis, looking at facility-wide antibiogram reporting and the understanding the use of the SAR and interpreting those results. So these are great training opportunity videos that you guys can look at and that are available. Any questions on this before we move to the next session? No, okay. I think somebody was coming off of mute, but okay, never mind. Okay, moving on to the next section, I will pass it over to Jasmine, our antimicrobial stewardship support, and she's going to be talking about the ICARS opportunity. So I can advance slides, Jasmine, and I will come off of mute.
Cool, thanks. Good afternoon, everyone. My name is Jasmine Wright. I am the Antimicrobial Stewardship Support on our AS team here at CDPH. Today I'll be talking about our Antimicrobial Stewardship Infection Control Assessment and Response Tool, which is also known as an ICAR. So this Antimicrobial Stewardship ICAR is intended to aid an ICAR facilitator in the review of a healthcare facility's antimicrobial stewardship policies and activities. This review should be conducted with antimicrobial stewardship leads, if possible. AS leads include pharmacy representatives, infection preventionists, and physicians. The ICAR helps to identify your facility's capacity to detect, report, and address healthcare-acquired infections and/or outbreaks. So there are 4 categories to the ICAR. The ICAR is a tool formulated by the CDC, and the categories listed here focus on these CDC core elements. So the first category is leadership, commitment, accountability, and stewardship expertise to improve antibiotic use. Then tracking and reporting antibiotic use and outcomes, actions and activities to improve antibiotic use, and lastly, education of healthcare professionals, patients, and their families. So this is a visual of what the actual ICAR looks like. This is the ICAR that will be sent to your facility via email. It is a 4-page document with questions assessing your antimicrobial stewardship program. So completing an antimicrobial stewardship ICAR allows for a fresh perspective on your existing AS program. It prepares facilities for regulatory surveys. The ICAR helps with infection control risk assessment priorities and planning activities. And lastly, provides a summary report of opportunities and strengths for each facility's antimicrobial stewardship program, as well as resources and education if needed. So this is the process of how the ICARs will go with the facilities. So the first step is the ICARs will be sent out to the antimicrobial stewardship leads at each facility. The ICAR responses are then analyzed by the CDPH antimicrobial stewardship team. So our team consists of the antimicrobial stewardship lead, which is STAR, our epidemiologist, and support. The next step is to provide customized feedback and identify areas of opportunity. And lastly, we will provide written recommendations to the facilities based on results via a site visit in person or virtually. And now we will open up the floor for questions. Feel free to come off of mute or put your questions in the chat.
Thanks, Jasmine. So if anybody is interested in doing an ICAR or collaborating with us, please email us at the CDPH at cityofchicago.org, or you can email me directly. Our contact information will be on the last slide. If you guys are interested in doing an ICAR that we can collaborate with you guys on. So yeah, any questions? We do have 2 announcements after this, but we had saved some time for questions regarding any of the topics that we talked about today. If you guys want to drop anything in the chat or come off of mute. Okay. The last 2 things that we wanted to mention, this is a Midwest Antimicrobial Stewardship Collaborative that is hosted by MASC, is what the team is called, or the group. They are looking for abstracts in infectious disease. So this is a great opportunity for medical residents, pharmacy residents, or nursing students, anyone who has an abstract that they would like to be submitted for their virtual symposium that they're going to be having in, I think it's in May, yeah, May 23rd. So they're looking for abstracts. They're only taking 12. So the first 12 that are submitted will get the opportunity to work with this collaborative, and submission deadlines are April 22nd. So you have a couple days. It's not due until next month. So if anybody's interested, I can provide you more information. And the email is at the bottom that you guys want to, if you guys want to submit any abstracts to for any of your students or residents. So there's that. And then lastly, we wanted to gather some feedback, so we created a feedback survey for our work group. You can scan the QR code, or you can click the link or on the slides once we send them out, or copy and paste. But we're looking for feedback on this work group on how we can better support you and your facilities, things that we're doing good and things that we need to work on, or other topics that you guys may want to see for future presentations. So we're welcome to all feedback. Please, if you guys can fill out the survey for us, it would be super helpful. And I think that is all that we have for today. So I'll leave this on for a second so you guys can scan on your phones. And Jasmine has dropped the link also in the chat for you guys to easily access. But yeah, that is all we have for today, so we can conclude early. Please, if you guys have any questions, don't hesitate to reach out to me. I do just want to make an announcement. Matt, which was our NHSN technical support, is no longer with our team, but we do have Jasmine who will be taking over that responsibility. So if you guys have any questions regarding your NHSN technical support, please email her or myself with any questions. Thanks, everybody. Have a good weekend.